afternoon to all of you, and this is a formal welcome to the 29th edition of Medicall. This afternoon we have the session on equipping and managing ICU efficiently, and I'd like to invite Dr. Manivandan over to the dais to give you all the introduction. Doctor needs no introduction at all for himself. Managing Director, Kauvery Hospitals and CEO of Medicall. He'll be doing the introductory session. Over to you, Doctor.
Good afternoon, everyone. It's really a very pleasant moment where I'm talking in a seminar regarding ICU. I'm basically an anesthetic and critical care physician, but I haven't touched the patient in the last 13 years. So I'm just giving introduction to people who are day in and day out handling patients. So I'm basically an anesthetic and critical care physician, self-proclaimed critical care physician, trained critical care physician. Started my practice in Trichy, started our Kauvery Hospital way back in 1999 with 30 beds. Then over a period of time we have built multiple hospitals and multiple ICUs. So the last 12 years I've stopped practicing and into administration, taking care of new hospitals and projects. Over a period of time, the last 16 years we have been running this show, Medicall, primarily to help doctors to source the right kind of equipments. And also we do these seminars right from first show onwards the last 15, 16 years. The theme of the seminar is everything they fail to teach you at medical college. Medical college or postgraduate degree, we have been trained how to treat patients, how to treat critically ill patients, how to operate on critically ill patients, or how to give anesthesia. But no one teaches us about how to manage ICU, how to equip an ICU, or how to manage a hospital, finances, marketing. No one teaches us. So that's the main aim of these seminars, where we teach everything that medical college failed to teach you. So ICU is something very, before giving the intro about the speakers, so ICU is something very close to my heart. And in Trichy, when we started the hospital, at that point of time, people were traveling to other cities for critical illness because that town didn't have a good ICU. So myself and my colleague, both of us are anesthetists, we were there around the clock offering the critical care services. We were just trained critical care physicians, we were not properly trained in a structured way. But we made a lot of mistakes, we learned from them. Of course, when my later after many years when a really well-trained critical care physician started managing our ICU, we realized that clinically they have been doing extremely well. And we'll be wondering why, in spite of the lack of that great clinical knowledge, our ICU was very popular. And people really respected and trusted our critical care. One of the few things which made people trust us was we had a regular communication with the patients. Actually, okay, we have been communicating with the patients on a regular basis. We are brutally honest, as a lot of people were talking in the previous seminar. We're very honest with the patients. We never gave false hopes to the patient. And we've been very ethical, and we ensure that early ambulation and early discharge of patients wherever possible. The length of stay in ICU was very less. Actually. These are few things which I think that our ICU got a good name. But more than that, the first ICU which we built was probably 200 or to 250 square feet, that's all. We had 8 beds there. It was doubling up as ICU as well as post-operative ward. When we built the first hospital, we didn't know how ICU looked actually properly. We had limited experience outside. And it was so cramped, no concept of infection control, nothing. The doctors and staff didn't have their own restrooms or something, nothing like that. No clean utility, dirty utility, those kind of things. And luckily most of the patients survived actually. Then after some time when we gained some experience, when we see a few hospitals, and then we built a better ICU. We thought it was a good ICU. Then over a period of time when we moved to Chennai and built bigger ICUs, when we recruited the people like Sridhar who came from UK, and the concept of ICU itself changed. Currently, the concept of ICU is very simplistic, and all of you will think that ICU is a complex environment, so we need complicated gadgets and all those things. If it is going to be complex, then outcomes will not be appropriate. I can say that, say when I went, when Dr. Sridhar, who heads our ICU, will be the next speaker. He was alumni of Madras Medical College, where I also did my undergraduation. He was in UK, so I went to UK to meet him, to convince him to come to India to set up his critical care practice. So he was managing a very big ICU, 60 to 70 bed ICU those days itself. I said that we just started a hospital in Chennai, why don't you come and manage it? So he said that, I will not be the right person to manage your ICU. I said, you're managing 70 bed ICU, why you are not the right person? He said, I'm not commercially viable critical care physician. I said, what do you mean by commercially viable critical care physician? He said that I don't prescribe antibiotics most of the time. I intubate rarely, I wean them very fast. So commercially it may not be viable for a corporate hospital like yours. Always doctors stress on the corporate hospital like yours, because the corporate hospitals are all money swindlers like that. So I said, of course we are corporate hospital, but doesn't mean that we want to make ICU money out of ICU. Okay, yes, of course we'll also make money, but in an ethical way. So at the time he was managing 70 bed hospital, he came here and started managing 15 bed ICU actually. And of course, when ICU made enough money, very ethically, and we were very cost effective and compared to our similar hospitals. So simple things like infection control or early ambulation with less amount of drugs, okay. All these things ensure that our outcomes are very good, and because of that, or one of the outcomes of that, pharmacy minister got admitted in our hospital, successfully discharged twice or thrice, and of course later because of voltage and other things, we couldn't save him. And also during COVID times. During COVID, it was a very interesting thing where there was a huge load on the critical care. We had to manage it efficiently and also cost effectively. The government came with a price cap on ICUs and other things. So we are not having a liberty to treat them, give any kind of medications. So it was a very interesting challenge. In fact, a lot of hospitals started showing keen interest in setting up ICU during COVID and after COVID. They realized that if you want to run a multi-specialty hospital without critical care, then it becomes difficult, it will become outdated. So a lot of hospitals have started the ICUs. So we thought this is the right time to share our experience of running a good ICU or equipping an ICU. How to run it cost effectively, that's very important. Cost effectively because we should all understand that most of the patients pay out of pocket. They can't afford a very high cost treatment. So we need to optimize the care and evidence-based. If you do practice evidence-based medicine, we can definitely offer cost-effective critical care. Outcomes will be very good. I'm sure that the speaker, Dr. Sridhar and Mr. Venkat from India has been instrumental in setting up huge medical college hospitals and running and setting up ICUs in many hospitals. We've got amazing experience on infrastructure, equipping ICUs and managing ICUs. So I'm sure that the speakers in this program will highlight the best practices which they have seen in their practices. And India needs more hospital beds, more critical care beds, because currently the disease pattern is changing. Most of them have got chronic diseases. So sepsis, multi-organ failure, all those things cannot be handled in a non-critical care setup. We need a critical care setup, but optimal critical care, I can say, will definitely improve the revenues of the hospital as well as brand image of the hospital. I am sure that these seminars will help you to set up your good ICUs, and of course we will be talking about new technologies. I don't know whether the speakers come. We will talk about digital ICU also. That is also upcoming topic. And thank you all once again for a good response for all these seminars, and I also request you to see the exhibitors, because exhibitors are the one who bring medical money actually. So we need to support them so that next time they are also there in the show. Thank you all. So we'll start the lectures.
Thank you so much, Doctor. I'd like to invite Dr. Sridhar over to the dais. An undergrad and postgrad graduation from Madras Medical College. Dr. Sridhar obtained his advanced training in critical care from UK and currently he heads critical care at Kauvery hospitals.
Before I start, I think the first question that Dr. Manivan asked me was, how long is my talk? I told him about 40 minutes. I'm a rather introverted guy in things I can't talk much. So he said, your entire life you would have spoken for 40 minutes. So this is my challenge, to fill your 40 minutes with talk and words. So actually I prepared only for 20 minutes, but to take on Dr. Manivan's challenge and fill the 40 minutes, I'm going to start with a story, which will somehow relate to ICU as we go along. We're all human race, we all evolved over millions of years, and for the last 200,000 years we've all been part of human species. We're all proud. Egyptians say they built their pyramids 5,000 years back. We say Tamil language is the oldest compared to all other languages. We're all proud of our cultures. But in which culture do you think a civilized culture actually started? You understand my question? So we have engineering novels, we have pyramids, we have Colosseum in Rome, we have literary marvels, we have wonderful art scattered all over the world in various cultures. But when did civilization, human civilization actually start? Any guesses? So this question was asked to a great archaeologist called Margaret Mead, and they're all expecting the same answer. She said it's Egypt or Britain for its imperial conquest or literary conquest. And she said the first civilization started 15,000 years ago. And they asked where and how did you arrive at this? She said when we were digging through various archaeological sites, she found a skeleton. And in this skeleton, the long bone, the thigh bone, the femur was broken and it had healed. And this skeleton was aged about 15,000 years back. And she said, this is the point where we know human civilization started. And people still didn't understand. They asked, what has a healing femur bone got to do with civilization? Now we all know when the femur bone breaks, it takes at least 6 weeks to heal. During the 6 weeks, somebody has to take care of that person. They have to move them to a safe place, they have to get food for them, they have to protect them from other predators that are going to attack them. No other animal with a broken thigh bone from any of historical time or even present time can survive. A broken thigh bone means the animal is prey, the animal cannot hunt, cannot feed. Whereas 15,000 years back, somebody took care of this human, and that is when civilization started, because that's when it means we were able to take care of fellow human beings. It is the birth of medicine, and this, she said, is the birth of human civilization. When we start caring for our fellow beings, we are able to take care of them. Similarly, in an ICU, when somebody cannot breathe for their own, or their heart cannot pump for their own, or the kidney cannot do work, when we are able to take care of these patients, it is a height to which any hospital can reach. And right now, as people grow older, we are reaching a stage when the diseases become more and more complex, and we have to take care of patients with increasing complexity, with heart problems, kidney problems, lung problems, even before they have new problems added on to them. So, a good ICU is able to take care of all these patients, is the backbone of any multidisciplinary hospital. So, my talk, I think, is on how we equip and manage ICU efficiently. And I don't want to talk on extremely complex stuff like ECMOs or AI. I want to talk on something that I hope will be relevant to all of us. So, I'll try and simplify it as much as I can, but at the same time, I'll keep it as practical as I can. So, which group of patients need ICU? So, essentially, patients come to ICU for two reasons. Either they need monitoring, they've had some complex process, surgery or procedure, and need to keep a closer eye on them. Keep a closer eye on the temperature, make sure the blood pressure is okay, make sure they're passing enough urine, they're eating the right amount, enough fluids are going. So to keep a closer eye on them, it's not possible to do on the ward. Or two, they need some form of organ support. If the heart is not working, we need to keep an eye on it, we need to give inotropes. Or the lungs are not working, we need ventilator support. Or the kidneys are not working, we need dialysis support. So either to keep a close eye on patients, or to support their organs. So I just thought I will take a patient journey, illustrate how we can monitor patients and use our equipment more appropriately. So let's take a patient coming for a complex GI surgery. They're going to come and have this Whipple's operation, for example. It's a long operation, it can take several hours, and depending on the health of the patient, they may need a lot of support during the operation and also afterwards. So they're coming to a center where they need to be looked at. And generally, you look at quality, people look at three aspects: structure, process, and outcome. So in this case, what do we want? We want this patient to walk out. We want good quality of care. At the same time, we don't want them to acquire hospital-acquired infections or have any medical errors that are quite common when dealing with patients who have got multiple problems and multiple doctors and nurses are taking care of them. So what structures do we need? We need to have a good operating theatre, we need to have the necessary equipment, and we need to have human resources. When you talk about human resources, I'm talking about just doctors and nurses. I'm saying we need to have somebody like an infection control nurse. So our ICU has got an infection control nurse whose job is dedicated to looking at the ICU. So if you walk in and you wouldn't touch your patient without washing your hands or putting hand gel, she will step in and say, "Sir or madam, please put your hand gel or scrub your hands before you touch the patient." If any patient has got an infection that is at a high risk, we want to protect that patient and also protect the other patient. She'll come and tell me, "This patient has got this multi-digestion bug, we need to move in this side room." So we need somebody like that. And they are part of the structure, not just the equipment and the people in the buildings. And then we need to have processes. What do we mean by processes? Processes mean the culture of the organization you're working with. How we cooperate with each other. Hospitals are complex areas where we do complex things with a lot of people. And there's nothing more complicated than individuals working separately in silos. So we need to create a culture wherein they cooperate. And once we form guidelines, we must stick to them without compromising. So for example, in our ICU, we say every time an injury is put, we need to have a chest X-ray before you feed them. Now 90 times or 100 you get away with doing a chest X-ray, but when it happens once or twice, the tube goes the wrong area and you put feed into that, we cause a lot of problems. So very often they say, I'm confident, I put 50 ml of air, X-ray man and the patient. It's very easy to slip down that route, but we must ensure that the nursing care, the doctor take care, uncompromisingly stick to whatever protocols we form. And in fact, when we have an ICU, when I go on ward rounds and I try and, like Dr. Manivan said, he stole me from UK and brought me here, I try and steal ward nurses to the ICU. And the ward nurses I pick are the ones who are uncompromising in what they do. They will not bend. They will not do it just because the doctor says so. They stand up for themselves, they stand up for patients, and they show spirit in it. And if they do this, then the place that they are recruited to is ICU, because I want people who stand up for what we are doing and will not compromise in the process that are set there to protect the patients. And when we do all this, we ensure that the outcomes are as good as we can and we reduce medical errors. So equipment in ICU, everybody knows we need ventilators, we need pumps to give drugs, and we need monitors. As far as possible, we need to standardize them. We have nurses and doctors, and when we start off, we can't have, if you have 4 different ventilators, they can't all be of different models and different makes. To simplify things, when you're driving a car, you're used to the car, and if you go and take another car, the same model make, you're going to drive it easily. You can't be moving from an automatic car to a manual car. It is possible, but you will have starting problems. And every time that happens, the person who suffers is not you driving a car, but the patient at their end. As far as possible, ensure that all your monitors, all your pumps, and all your ventilators belong to the same brand. It doesn't matter which one you choose, as long as the same, because it reduces errors. We all know nursing turnover is high, and it's hard enough for them to get familiar and comfortable with one ventilator rather than learn 3 or 4 different types. Ventilators, what type? I'm not going to say any one ventilator is better than the other, but I would suggest that you choose a ventilator which is multi-purpose. For example, if this patient is coming from the theatre and needs a period of ventilation, you can put them on invasive ventilator, and then there are ventilators, you can extubate them, and this patient needs non-invasive ventilation, the same ventilator can provide this. And then you take them off and you need high flow oxygen, the same ventilator provides high flow. So you're not switching equipment, you're not adding to the cost, and everybody's job is easier. You want me to name one? I think I would name the air liquid ventilators, which is not what we use. They are made in Chennai, or at least assembled in Chennai. They're from actually a French brand, And they're probably the cheapest ventilator that does all the three things together. They can provide invasive ventilation, non-invasive ventilation, high flow oxygen. It's important to have battery backup. You also know power can fail anytime, so if you don't have good battery backup, it can cause trouble, so don't compromise the battery backup. And also ensure the ventilator that you buy is transport compatible. You don't have to buy the biggest, most expensive all singing and dancing machine. The ventilator that I mentioned can also be used to transport the patient. So if it is going to a different hospital, if it is going to a CT scan, then this ventilator can combine and do all of these things. We work in a hospital which is got everything, so we have compressed oxygen, we have compressed air. So if you work in a hospital where you do not have these things, and you don't have compressed oxygen air, then it's important to buy a ventilator that is turbine based. So these ventilators don't run on compressed air. They use turbines, they themselves take air from the atmosphere, compress it and push it. So it's important to think about these things when you're buying these things, and it's also important to check that the ventilators offer good service backup later on. When you're buying an infusion pump, you can use a pump to give feed to the patient, you can use a pump to give fluids to the patient. Once again, try and make them multi-purpose as possible. I'll show you the next slide, a pump that does both. I'm not trying to promote anything, I'm just giving you pictures of companies that offer that. And the third thing that we use are monitors. So we all know about monitors, there are wires coming to the patient, but now there are wearable monitors available. If the patient is coming in just for monitoring, I once again talk about the monitoring pad that we use. It is a Bluetooth solution, it's stuck onto the patient, it continuously monitors the patient. The patient can get down, walk on their own, there are no wires holding them down. At the same time, you're continuously monitoring the patient. So wearable monitoring vis-a-vis traditional monitoring. So these are some manufacturers of turbine-based ventilators. We use the ResMed Astra 150 a lot. It's a small ventilator. We use it to transport patients. We use it for NIV. It can be used for invasive modes. And sometimes we use invasive ventilators. We use limbs, two circuits, two inspirator limb and expirator limb. And then a portable ventilator has got just one limb. ResMed has got two limbs. We take the two limbs from the invasive ventilator, stick it to the ResMed, and off they go to the scan and come back. Or off they can be transported and come back. It's got good battery backup and it's turbine based. I do not have to worry about compressed oxygen. I don't have to worry about compressed air. So this is just one of the things that we use as a sort of a one ventilator fits all size. And these are cheaper. They're 4 lakhs. The adequate one is probably 7 lakhs, whereas the standard ventilators, all singing, all dancing, massive ones are 11 to 12 lakhs. And most patients in ICU, we're not working in a purpose-built massive ICU, will need NIV support. And these ventilators are more than good at providing. Okay. So this is a pump, once again made, or at least assembled in Tamil Nadu. So this pump is dual pump, it's smart, it's 2-in-1. It can be used for both enteral feeding and also for giving IV. So you don't have to be buying many pumps for many things. Okay, so this is the patch that we use. It goes onto the chest. It's wearable. It's FDA and CE approved in India. It's sold by Life Signals. It's made by a company in USA. And this one we have been using for patients who are stepping down from an ICU. So when they go out from here and they go into the ward, in ICU they are monitored 24/7. In the ward they are monitored maybe once a shift or maybe twice a shift. And when they go there, the monitoring frequency comes down, and sometimes some of these patients can have unexpected cardiac arrests. So we used this for about 3 months, and the rate of cardiac arrest came down dramatically. It was quite low before, but it came down dramatically, and now we're using these. So the patch is connected to this, and this is the computer that sits in our ICU, and each box there is a patient connected to this patch, sitting on the ward, and we're keeping an eye on them. We do not keep an eye on them using anybody very complex. We have an A&M, who's basically somebody who's passed out and has gone some basic training, and all that he or she has to do is look at it, and if it goes off beyond the preset parameters, either oxygen or heart rate or the ECG rhythm, they have to go and check that the patient is all right, it's not a false alarm, and if it's not a false alarm, then they activate the med call where the doctor and nurse immediately attends them. So we have a 24/7 solution for somebody not only picking up data. All data is meaningless unless it's actionable, and the presence of an A&M ensures that the data we're collecting is converted to action. Now, this we are using outside hospital. If you are starting an ICU in your hospital and it's not yet fully geared, you don't get full-fledged ICU, you could create a digital ward where patients are sitting there, they're completely monitored using wireless solutions like one of these. This serves a purpose if you don't need high-end invasive arterial pressure monitoring or things like that. And then what do you do when you're going around? Many people, in our hospital we have dedicated intensivists. Our job is only to take care of patients. I understand that in people who are practicing in tier 2, tier 3 cities, you're running your own busy hospital, you have OP to see, you're doing a lot of things, and then what do? You have to empower your team. So these are mnemonics that are used widely in ICU. So you go, you forget about whether the patient is being fed or not, whether the patient has got pain relief, whether they have any indwelling central lines or urinary catheter that needs to be taken out, whether antibiotics need to be stopped. One of the keys of taking care of patients in ICU is to de-prescribe as soon as possible, in other words, to reduce the amount of medication they're on and take away unnecessary tubes. So drug de-escalation, indwelling catheter removal. And you will forget, unless this is your only job, you're doing a lot of things. So empower your nurses. So as I said, we pick nurses who stand up for themselves, who will do what is right and will not compromise even though a professor is telling them that they are wrong. So that's how our nursing staff is chosen. So likewise, if you have a fast hug BID, give a patient a fast hug twice a day, BID, then you cover most of the basic aspects. And these are mnemonics. The easier way to do this is to use electronic medical records. Once again, this adds cost to you, it adds time, and you have to have people trained to this. If you don't have an electronic medical record, then it's a simple way you go over it quickly. Even a nurse can go over it and say, doctor, the patient has been on antibiotic for the last 7 days, 10 days, you want to stop. Central line is there for the last 10 days, you have not used it, you want to take it out, it's a source for infection. So simple prompts to help you do what you're doing. The other thing that we do is, patients like this, for example, the surgical patient who came along, they can become sick and they can have a cardiac arrest. Now, that is cardiac arrest is not the time to shout at nurses or point out Indian places. You do it when you have a quiet day. Right now, our ICU is quiet, so we take out the mannequin which costs about $1 lakh. The mannequins are available much cheaper, available for 15,000 from Ladle, where the basic mannequin, and you run a scenario. You say, right, this patient is going down, is having a cardiac arrest, how are you going to do it? So usually, traditionally, we have these huge simulation centers that are far away in countries abroad and also India, and then you go there, you learn how to do this, and then you come back to a hospital which has no relevance to how that simulation center was set up. We need to do simulation in our hospital. We need to do simulation using the equipment that they have to hand and that they are familiar with. And this is called in situ simulation. In situ is the word for do your simulations training on site. All you need to do is to pick up one doctor, one nurse, or one physician assistant who is interested in this, send them across to those areas where they train, bring them back, and they train your nurses and doctors regularly. You do this frequently, you run simulation drills, you run cardiac arrest drills until you're good, and they practice on mannequins where even if they do mistakes, nobody comes to harm, and they're switched on and they're running for an actual cardiac arrest or actual medical comes out. So a simple simulation center using simple interval mannequins which cost 15,000 to 20,000 rupees will help you. And this also helps in role play, it helps in communication, all of which you're trying, you're practicing out in a non-pressurized environment and no patient is at harm. No substitute for simple in situ simulation. This is something which is probably not very clear, but we're happy to share. So these are drugs that we give. The patient is becoming sick, say the patient has come back, the people says he now needs inotropes, and you're going to tell the nurse, please start non-drug. How are they going to start? They have not done this before. It says what drug needs to be taken, how many ml of it, what it needs to be diluted, and what rate it needs to go. No fancy started at 10 mic per kg per minute calculations. We don't use that at all. It is ml per hour. Take this much ml of this drug, put it in this much ml of saline or dextrose, and start it at this much ml per hour. The moment you start using calculations, it brings errors. So you do the calculations, but simplify it for the nurses. So there's a list of our infusions that we use. Happy to share if you want to get in touch with me. You take it back, and then everybody uses only this. No doctor comes and says, give potassium at 20 millimoles in this. Another doctor comes and says, give potassium like that. And then it causes confusion. Nobody knows what's going on. Standardize everything, simplify everything. It uses these charts as the memoirs. Even I, when I prescribe something, I want to make sure that I prescribe it in this protocol so that all the nurses will use the same. So in assisting people, there are a lot of needles and sharps going around. This is something we developed. So this is basically a sharps box. The plastic box is a sharps box. The tray is where they can break the ampules. You can see ampules that are hanging. And then there is a box where the blue color plastic is in a box. We're using some wipes, so those wipes, which are in the box away, we're reusing them here. So ampules are cut, the sharps and the needles go into the sharp spots, the other plastic non-dangerous bit go into the blue plastic cover and is thrown away. And this tray is at the height of the average nurse. So it is very ergonomic, and we move to cardiac situations. It strongly reduces the number of needle slit injuries your staff will have. And that's one of the important things we need to take care of our staff. So you're in a scenario where this patient is becoming sick, you want to know what is going on, you send it to the lab, it takes 1 hour to reach the lab, it takes 3 hours for them to process it, and it takes another hour for them to report it. I want to know information now. So these are called point of care testing devices, quite widely used. Our ER has got one, ICU has got one. This I think is made by a company called Abbott. It costs about 3 lakhs I think. You can buy it and you have information. Now, is this patient having a heart attack? You do it at the right time, the troponin I comes back. You don't wait 3 or 4 hours till results comes back. You are empowered immediately to know what is happening and to start the right treatment or call the right cardiologist. These are point of care testing devices. They cost 3 lakhs, but if you say I'm going to be using 30 cartridges or 40 cartridges, they'll even give you these machines for free because you'll be using the cartridges and they make a profit from that. So please consider equipping your ICU with this if you don't already have one, ICU and ER. Another thing I've noticed is if you're a smallish hospital, try and keep your ICU and ER together. You may not have that many doctors, that many nurses to look after all of them. Try and put all your resources together so that the same person covers emergency and ICU is one other option. At bigger hospitals here, you have separate teams running both. Physician assistants, increasingly I think the numbers are going up. Somebody told me, asked me, as 2,000 physician assistants will be coming out every year. We use them a lot, we train them up, and they are an invaluable resource. You just need to support them initially. And you won't believe it if I say some of my trained physician assistants can get lines in using ultrasound when the anesthetist can't get it. They're that good because that's what they do it repeatedly and they become good at it. So if I have a patient who needs a line difficult, these are people I go to and they are available, and it gives them the recognition that they need, that they're doing something more directly in patient care. And if this patient needs to go to CT scan, they are used to ventilators. I just look at them and say, please take the patient to scan, and they will take the patient to scan. I'm not using a doctor or an anesthetist to take the patient to scan, come back, the doctor and anesthetist is still available to attend to emergencies, whereas the patient at the same time as somebody who is doing this regularly and hence is good at it and is protected on their way back and forth. So initially when I was given this topic about latest technology and equipment, I thought I'd talk about something like this before I decided to make my talk practical. I'll talk about this as well. So this is increasingly about using AI, artificial intelligence in medicine. So this is the protocol being used in Oxford. So somebody comes with a stroke, they will do a CT and decide is there a hemorrhage or not. No hemorrhage, then they go to the next step, which is to do a CT angiogram, which is to see if the large vessels are blocked or not. If the large vessels are blocked, they can offer thrombectomy. And if this is also the large vessels blocked, and then they go on to the CT perfusion scan, and that shows how much of the brain is viable. You do all this 3D, and this comes on your phone, and it tells you what needs to be done. It doesn't even involve a radiologist, it doesn't involve a neurologist. The artificial intelligence itself is able to read this and give you this. So this is actually being used. I'm not talking about the future, these are actually being used. So all these things will come over to us and will help us. But until that does, what do we have? We have tele-ICU. So tele-ICU is once again very complicated, very expensive. Philips and GE came out with various solutions. They are very expensive. And we ourselves found it expensive despite the number of patients we have. So all you need is a video software. I'm not going to say WhatsApp, oops, I said it, but something like that. To pass information on to a specialist who are not on site, who can look at images or look at echoes or look at patients, look at patient breathing pattern and guide you. So all we need is a video software which nobody else in fact can do, and nobody else is keeping their personal phone, but you have a tablet that's dedicated for doing this to help you with this. Okay, so this I just put in. So this is once again a screenshot of our computer that sits in the patient counseling room. The patient will sit on the sofa or the chair there. We record all our conversations. Sometimes our conversations take 10 minutes, 20 minutes. They're very hard to write down everything that we say. So all conversations are recorded. We have the patient, so nobody says, you need to tell us that. The complications are not discussed. And immediately the patient does know that you're recording it. they know they can't come back and later tell this. It's sad that we need such things, but we all know that trust deficit is high, and trust deficit can be especially high when talking about critically ill patients. So this is another piece of equipment that we have, clearly not related to patient care, but just to protect ourselves legally. This once again is something that we are doing more and more in ICU care. What you realize more and more in ICU care is that the less we do, the better it is for patient. The less we do, the sooner patients get better, the less invasive lines we do, the less time they are on ventilators, the less blood tests we do, the less oxygen we give them, the less TPN that we use. Everything is coming down to less. So the less we do for the patient and let patient recover alone, we find that patient outcomes are better with less infections. So this is something that we have once again had in Kauvery. Like I said, all data has to be actionable. So down below we have the second message that I got from my phone is some patient whose potassium is 6.5. We send the labs and I've forgotten about it. But this alert reminds you. And this is very useful. You're able to connect your labs, give them critical alerts and say if this threshold is beyond this, please alert either ICU directly or the doctor the patient is under so that the data can be actionable. I want to know this at 8 o'clock at night when it happens. Maybe at 9 o'clock, you can have a delay, but no longer than I don't want to sleep and wake up next day to know my patient of mine has 6.5 in the evening, and this is gradually kept up. So this is something I just picked up today. So we have a dog whose last both its hind legs. The job of the dog is to defend the territory, to run, to bark, and then with appropriate structure using some plastic tubing and discarded beams, we're able to do that. The dog is able to do the process it is supposed to do, and we have a good outcome, a happy dog that does what it does. So we don't need the latest artificial robotic technology, but we can have something, we can cobble together something that works. And while I'm doing all this, I can see that Dr. Maniman has left, so I no longer need to bore you for 40 minutes. I can go on and say, thank you, I've said what I wanted to say.